Happy Friday. Welcome to Project Echo Geriatrics. I'm Kate Bennett, the medical director for Project Echo Geriatrics, and I'm glad to be back in person. I've been traveling around and have been more of a participant lately, so this is great to be back. Today is actually our 3-year anniversary of this Project Echo, so thanks to those of you who have been with us from the beginning. And I'm happy to have everyone who's joined us along the way. We have a fantastic speaker today. We're going to get started with that. We have Dr. Teri, who is, she told me, a clinical psychologist by training, but she is a professor in the School of Nursing at the University of Washington, and she has dedicated her career to the non-pharmacologic management of behaviors in those with cognitive impairment, and has really worked on creating and studying ways to approach these behaviors and to train caregivers of those with dementia to address these behaviors in the right way, which is without medications. And she's going to talk to you about this. And as I always do on Echo, I try to ask her to distill this whole gigantic body of work into a 20-minute presentation, and she so kindly agreed to do so. So thank you so much, Dr. Teri, for joining us.
Thank you, Catherine. Can you hear me okay?
Yes.
Yes.
Great, great. Well, thank you to Catherine and Amy for inviting me, and Catherine was kind of only half kidding. When she asked me to do this, I didn't realize I had to distill it down to 20 minutes. So hopefully I have kept the heart of the presentation. And for those of you in the room, thank you for taking time out. I know how busy you all are. So I am trying to hit the high points of 30 plus years of research, staying on the most current. And I'm glad to answer questions at the end or after this. I'm an easy email, lterry@uw.edu. So you can feel free to reach out if you have some questions. The topic that I'm going to be presenting is evidence-based behavioral approaches to dementia care. And if I could have the next slide, please, I would appreciate it. Thank you. So this is what we're going to cover today. We're going to start out, I'm skipping all the usual beginnings. You folks know what dementia is. You know what Alzheimer's is. You know the behavioral problems. So I'm going to focus on the treatments, evidence-based. I'm going to give you the rationale to our approach, which began in about 1986 and hopefully has gotten better and better and better over the last 30 years. We have conducted at least a dozen randomized controlled trials in various settings with various population groups. And we have been doing community-based and clinical services-based research for the past 10 years or so. So hopefully it'll be relevant to your practice, and you can take what is useful and take it home. The key elements of the program is basically 4 pieces, if you will. The first is realistic expectations, and it's teaching caregivers and staff what to expect when working with people who have severe cognitive impairment. The second is communication, teaching people how best to communicate, how to understand people who are maybe non-communicative or people who have very low thresholds of patience for communicating. Pleasant events is a cornerstone. The realistic expectations and communication you can get from other places. I will talk about it a little bit. But pleasant events is a cornerstone, pleasant activities, because there's a fundamental data that suggests that people who have cognitive impairment can't engage in what they used to do, that they used to enjoy. So it is our job to reintroduce those activities and improve their mood and improve the quality of life. And then finally, the ABCs of dementia care, which those of you that have had any behavioral training know the ABCs mean activator, behavior, and consequence. We have applied those to dementia care, and we work very hard at teaching family caregivers as well as direct line staff how to engage in that. And I'll talk more about that later. The next slide, please. So why behavioral treatment? I expect Catherine has given you the background or previous discussions, but medications, as you well know, can only do so much. They don't always help. They can stop working. They can cause unwanted side effects. They can be expensive. And fundamentally, they don't solve the problem, which is the interactions between the caregiver and the patient. Now, I'm not saying that there aren't biological reasons and physiological reasons for the problems people have, but I'm also very strongly a proponent that the interactions we have with our patients, whether they're demented or not, can cause and maintain behavioral problems. So our mission is to decrease those interactions in such a way that the problems get alleviated. Behavioral treatments are person-centered before person-centered was a word. They can be individualized. They empower the caregivers. They give caregivers a sense of hope in a disease that's often perceived as hopeless. And the data has shown significantly decrease in behavioral problems, reductions in functional disability, decrease in depression, improvements in quality of life in both the caregiver and the person with dementia. And again, I'd be glad to share references with you if you want that data. May I have the next slide, please? So what do we know about behavioral problems? Oh, I'm sorry, advance the slide, thank you. They're common, next, frequent, next, variable. So even though we know they occur, we can't predict on an individual basis what is going to happen. And I think that's probably the biggest frustration caregivers face. But we do know that there are some basic fundamental aspects around the behavior that we can help people understand. Could you advance the slide again, please? And we know that they adversely impact care and quality of life of persons with dementia and caregivers. And if you don't have the experience of seeing a behavioral problem, just go into any nursing home during meals or during bathing. Next slide, please. This is a very old slide, but I show it because I want to underscore the variability of decline in persons with dementia. These are data from persons with Alzheimer's disease who have been autopsied. And what you see is a tremendous variability in rates of decline and the slope. And part of that decline is absolutely due to not only health problems, but also behavioral impairments and disabilities. May I have the next slide, please? So my slide gets cut off about 2/3. I don't know if we can move it a little bit, but this is basically our body of work of interventions focused on aspects of the behavioral problems that persons with dementia experience. We call the body of work Seattle Protocols for obvious reasons. And as you can see here, we began by disentangling the problems that people experience. We started up looking at depression, 1997, 2005. In the middle of that, of course, we all write grants, so there was a study on agitation that was 11 sites across the country. We then increased to physical activity, and I'll talk about that study a bit more because that's currently ongoing as well. And then we included not only looking at family caregivers, but looking at staff. And do I have a pointer? Like if I move my thing, do I have a pointer? Maybe not. Okay. So if you look at all the things under the umbrella, those are our interventions. All of them developed from clinical experiences, and all of them studied through randomized controlled clinical trials. May I have the next slide? This just shows you we have always wanted our programs to go out into the world. We've always wanted them to survive. So we have materials that we are glad to share with you and share with people that you work with. Again, all you need to do is contact me. May I have the next slide, please? So these protocols, basically they're theoretically grounded, social learning and person-environment fit. And what that basically is, for those of you that are maybe not familiar, social learning is interaction theory. I can't quite see you, so I can't see what your reactions are, but if we were in a room together, I would be responding to your facial movements, to your hand gestures, and you might be responding to me. Person-environment fit means basically that we are very responsive to our environment. I can see people walking around. If you're in the room there, you may be responding to people walking around. Clinically developed and applied over 2 decades. In partnership, there's always a partnership if you work in clinical practice between you, the caregiver, the person with dementia, and your staff. We leverage the clinical skills of healthcare providers. By that I mean, I never want people to put their clinical skills aside. I want them to add this program to what they already know, what they already do. And it is standardized and individualized. I've said randomized trials many times, and it's also been community tested. May I have the next slide? So I mentioned realistic expectations, and that's basically giving families and direct line staff very basic information about dementia so they know. So you've probably heard this, I've heard it a million times. He would remember if he could. So part of what we need to educate people about is, no, he can't remember. So some of it's very basic. Identifying and increasing pleasant events and problem solving is what I'll be talking about next. Next slide, please. So these are the studies. RDAD is the exercise program. STAR-C, some of you may have heard about. We've used that in the AAAs and with DSHS. RDAD has also been employed with the AAAs. And then STAR has been employed in assisted living residences. Next slide, please. So let me tell you a little bit about one of the studies and one of the programs that's now alive and well. It's called RDAD, Reducing Disabilities in Alzheimer's Disease. It was looked at in terms of an active treatment. Colleagues from Group Health at the time, now Kaiser, and the UW. We had a control, which was routine medical care. The interventionists were master's level, social workers or PTs, 9 weeks, and the usual assessments, blind ratings. Next slide, please. So this, you see the results. The first graph shows you the change in percent of subjects exercising. When we began this study, we didn't even know if we could do it. We didn't know if people would exercise, if caregivers could take on that responsibility. And what this slide shows, if you look at 3 months, they absolutely could do it. It survived a bit at 12 months, but not very well. We didn't have boosters. It was a grant. We just did the training and then we were gone. But what you also see here is a change in the Hamilton. And the gold, which is why I think JAMA published it, is the patient behavioral problems. You see the light blue is RDAD, the white is the control, or in this case, the comparison. Those who received RDAD were much less likely to be institutionalized because of behavioral problems. And that was our goal. You'll see they were not less likely to be institutionalized because of impairment or increased cognitive problems, but that was to be expected. These were people with Alzheimer's disease. We weren't changing the course of the disease. What we were seeking to do was change the behavioral impairments. May I have the next slide? So let's skip this. We've already talked about that. Next slide, please. Next slide, please. Okay, so here's the ABCs. A is the activator. It leads to B. B is the behavior. C is the consequence. Now, I can kind of see you guys a little bit. You're very tiny, but would you raise your hand to let me know if you've ever heard or you've done the ABCs? I see 2 hands, 3 hands. Okay, so forgive me. I'll go through it in a bit more detail. This is something we teach caregivers. Caregivers often feel like things come out of the blue. Things are unexpected, unplanned, uncontrollable. So this is fundamental to helping them get a handle on the problems and realize that there is control, there is something they can do, and if they understand where the problems come from, they can change them. Next slide, please. So this is a card that we have. Again, something I'm glad to provide to you. It is the ABC problem solving plan. A is what happened just before. I don't mean historically before, I mean immediately just before. So somebody screams, what were they doing a moment before they scream? And the antecedent is tricky because we're often not paying attention. Before, we're only paying attention when it happens. So we focus on the B. What was the person doing? Where did it happen? Who was there? When did it happen? I often tell caregivers that I work with, I'm teaching them to be scientists. I'm teaching them to be detectives, to figure out what's really going on. And in the process of answering those questions, they often come up with their own plan. Next slide, please. Whoops, next slide, please. Thank you. So you can keep going and let's show the slide. Thank you. So I'm going to give you some common antecedents. These are things you may know about already, but the trick here is to have families understand, or direct line staff understand, these antecedents are what trigger the aggression or the agitation, catastrophic reactions. So you can see if they can start to identify, oh, the lighting is bad, they're in their room alone, they seem really tired, they can themselves begin to think, well, gee, if they're in their room alone and that seems to be what's getting them aggravated, maybe if I help them leave their room and be with other people, they'd be less aggravated. So it really is a matter of figuring out what are the components of the activators, of the antecedents, and then how can I change them to move forward and come up with a behavior plan. Again, as professionals, you know this. The trick is for you as professionals to teach the direct care staff and to teach families. Similarly to understimulation, overstimulation, too many demands, too much noise, loud voices, anything along those lines, if they're activators, then obviously what you do to change the behavior, you step back and you try to decrease the stimulation. So even that simple, knowing whether it's too much or too little, will help caregivers understand what the next step might be. Next slide, please. Yeah, you can go through this whole slide. Thank you. It's different when you do it yourself. Okay, so here are common antecedents to depression. Again, these are things that can happen prior to a person acting depressed. Now, I'm not saying clinically depressive episodes, I'm saying a demented person who's appearing sad. Reminders. I've actually had staff say, well, we have been taught to do reality therapy. So we remind her that her husband's dead. And when we remind her, she seems to cry. Well, what are we going to do? Well, it's okay not to remind her. So sometimes it's common sense, but sometimes it really is understanding what triggered that problem. An inability to participate in enjoyable activities. I am a quilter, my hobby. If I sit in front of a sewing machine and that sewing machine misbehaves as I get demented, I'm going to be very frustrated. And I'm either going to get depressed or I'm going to get violent. So it's going to be important for people to realize that they need to sit me in front of something that I can do versus something I can no longer do. Boredom, being alone, those kinds of things, all of that, we're sensitizing caregivers and direct line staff. Once you identify them, you can change them. Next slide, please. So antecedents, consequences, why keep it as simple as pleasant events? Why even focus on this? We know cognitive impairment leads to a loss of initiation. We know that when you engage in pleasant events, you feel better. We know that pleasant events are related to boredom and significant behavioral problems. So by doing something as, quote, simple as pleasant events, we know we can avoid or alter behavioral problems. And we know that that includes a range of problems, such as depression, aggression, and agitation. The other piece that I think is really important is it is so empowering for the caregivers, whether it's direct line staff or family, to realize they can identify something simple that can change the person with dementia's mood. The other piece, and I put it in caps on this slide, is every interaction has the potential to be a pleasant event. Sometimes we don't remember that. Sometimes we get so involved in getting the task done that we forget that we're creating the environment that the person with dementia is experiencing. We are it. So we need to maintain our equilibrium and our ability to bring pleasant events to the fore. Next slide, please. So oftentimes people can identify pleasant events, and by pleasant events, you think about what did they do that they enjoyed, and what can they still do. So I gave you the example of my sewing. I also am an addicted crossword puzzle person. When I can no longer do the New York Times crossword puzzle, give me a child's crossword puzzle and make it simpler and simpler and simpler so that I can continue to do the activities that I found enjoyable. These are a schedule that we developed years ago. Again, glad to make it available to you. It's just basically if caregivers or staff really get stuck and they don't know what to think about, this is a list and they can use it as an inventory. We've also, of course, in our research used it to see if we can create change. Next slide, please. So think about, what did they enjoy in the past? What do they enjoy now? And what they can do to change it so that it's small and doable, and realize that things will change, right? What they can do one year is not what they can do the next year. When we're talking about most dementias, they're degenerative, in the case of Alzheimer's disease, so we need to be open to change. They should be individual, and they should be simple and very easy to access. So daily, almost hourly activities, if you will. Next slide, please. This is, again, an old slide, but I keep it because I love it. It shows the change, the relationship between mood and pleasant activities. The kind of fuchsia color is a person with dementia's mood rating. Okay, I don't know where this would be. So if you look at baseline 1, there's the mood rating without any intervention. Look at treatment. This is when we engage in pleasant events. We actually structure the pleasant events. You can't ask for a more beautiful correlation than you see in that treatment section. Then it's an ABA design. Many of you know that design. We remove the pleasant events. Well, we didn't do anything bad. We just stopped structuring it. And people with dementia can't necessarily structure their own pleasant events, right? Look what happens. A drop, a significant drop back to almost baseline. Reintroduce the treatment, reintroduce the pleasant mood. Simple relationship, but it's really powerful, and you really need to see it, and you really need to be aware and have the caregiver be aware that this is not something they can plan Monday and expect the patient to do on Tuesday. There has to be continuity and there has to be direction, especially, of course, as patients get more and more severe. If you have a mild demented person, then they might be able to continue it on their own. Next slide, please. Okay, so in conclusion, I think I'm pretty good on time. I've covered the high points. It's communication, realistic expectations. It is pleasant events and ABCs. We know that we can reduce behavioral problems. We know that there's an improvement in affective distress and QOL. And let me tell you, the first study we did, we focused totally on the person with dementia, and we were amazed at the improvement in the caregiver. And now we know that if you can improve the person with dementia's mood, you improve the caregiver's mood. So having them work together collectively on pleasant events is tremendous. It helps them both. Different people, of course, react in different ways, so behavioral plans are always individualized. To learn how best to work with a given individual person, you need to teach the caregiver to observe and alter their interactions. They need to realize how powerful they are. They need to be comfortable and change what they do. And that takes a bit of time and effort on your part to help them get comfortable there. And their response will inform you whether you're correct or not. One of the things I say when I do longer trainings is one of the reasons I really like working with people with dementia and their caregivers is because there's no subterfuge. If I do something wrong, I know immediately. If I do something right, I know immediately. People with dementia respond to you, and by their response, you will know whether you're on the right track. May I have the next slide, please? So I'm going to end my talk with this little guy and then the usual thank you slide, but I really like this guy. He expresses what's going on. He's got a broken leg, and in this case, it's cognitive impairment. And I really, really hope that my colleagues in biomedical research will learn how to fix and prevent his broken leg. But in the meantime, he is carrying around this ball that we used to call excess disability. We can chip away at that ball. If you think back to my Seattle Protocol slide, we chip away at it. We have the programs on depression, on agitation, on exercise. They all have the current components that I talked to you about. They all involve ABCs, pleasant events, communication, and realistic expectation. They just focus it on depression or focus it on agitation or whatever. So we chip away at excess disability, and this guy's going to walk better. He's still going to be demented, but he will walk better. And that's really the take-home message to this presentation. May I have the next slide, please? I want to thank you for your attention. I want to thank Amy and the Zoom guy for doing this. This was new to me. And I really want to thank NIH and NIA and Alzheimer's for supporting my research. Thank you so much. I think we have time for questions.
We do. Thank you so much.